Hello and welcome to On the Edge. I'm Dr. Jonas Moses, and this hour we are engaged in a special report. This is a special report on public health policy and infectious disease. And I wanted to start the program with an introduction, a raison d'etre, if you will, for producing this, what I think is an incredibly important subject. Recently I was asked to co-develop and become the executive editor of a new medical journal called Rethinking Medicine. And the theme of this journal is the continuous examination and reassessment, or reappraisal, if you will, of medical and scientific paradigms. In thinking about how this journal would unfold, what it would look like, what kinds of subject matter were covered, and who the audience was, which arguably is any of us who are in medicine and science. I wrote a mission statement, and I would like to read that because I believe that that is really the stepping off point for this conversation today. What I wrote was that this journal is dedicated to the proposition that nothing remains static in our constantly expanding and evolving collection of fund of knowledge, including the co-joined realms of science and medicine. In accepting this universal truth, the inevitability of growth and change, we must also acknowledge there can be no sacred cows, no immutable dogmas or paradigms. For as soon as we cease to question the dogma and paradigm, we've lost the ability to engage in the fundamental processes of discovery, the scientific method. When we begin to elevate our paradigms to the status of deities, then we have also made of our science a religion. We are faced with a world in which there are many, many countries where disease is treated, evaluated, and then treated on the basis of a cough, diarrhea, sniffle, dehydration, wasting, without any serious effort at diagnosis. No history, no physical. Oh, this patient has a cough and has had a cough for 3 weeks. I'm going to give this patient a drug, and the patient will go out the door. If they're fortunate, they'll have a follow-up. But in many third world countries, they're fortunate if they have any health care at all. I've chosen to introduce this topic today with a conversation that goes back to 2003, when I had read an article about a woman in New England who had had a serious medical misadventure, and wanting to better appreciate what had happened to her and perhaps offer some guidance, I contacted her. Her name is Audrey Serrano, and after a long conversation at that time, it became apparent to me that Audrey really needed to speak with someone who was an expert in these issues regarding a certain kind of infectious disease and viruses, and I sought out my mentor and referred the two of them, and ultimately they worked together for quite some time, resulting in this conversation today. I'd like to introduce Audrey Serrano. Thank you so very much for joining us. I appreciate it.
Thank you, Jonas.
Audrey, rather than a long introduction, perhaps you would tell me a little bit about your background. First of all, tell me a little bit about what you're doing now, and then let's go back to when you were first diagnosed in 1994 and the circumstances of that.
Okay.
Where are you today?
Well, right now, I just, as of May 15th, I graduated with my associate's degree in paralegal, and I run my own organization, FamiliesAgainstAbuse.org, and I'm in the process of closing on my home and working on my health. I still have a lot of health issues, which will be lifelong, of course, from all the drugs I took for all them years, but still working on that.
All right.
And basically picking up my life and, you know, kind of starting over.
Let's go back 14 years or so. What was the circumstance under which you ended up in a doctor's office or in a hospital receiving a battery of tests?
Well, back in 1994, I had been dating a guy that was diagnosed as HIV positive and was on the cocktail. And
a drug cocktail of some kind?
Yes.
All right.
Yeah, he was on the AIDS cocktail,
okay.
actually, AZT and all that.
All right.
And then later on, I had ended up sick. I had borderline double pneumonia, had been diagnosed with borderline double pneumonia. And my mother had been begging me to go and get checked because of this man that was diagnosed with HIV.
All right.
So finally I did. My mother and I went, and when I went back for the results, it was an anonymous test. And when I went back for it, it came back positive. And
positive for an infection?
For HIV.
Okay.
It was a positive HIV diagnosis.
Okay.
And the people gave me a piece of paper, and again, it was anonymous. It just had some numbers on it. And I brought it to my doctor, who then in turn put me on AZT, Epivir, and I was also on Bactrim.
And what else?
And then,
what happened thereafter? Did you get better?
No. I continuously had the diarrhea. I acquired colitis. I was constantly tired. I had no appetite, no energy, none of that. Then she subsequently...
your doctor?
My doctor at that point in time, right. She closed down her office. So she in turn sent me over to Clinic 7, which is an AIDS clinic. They only treat AIDS patients.
Okay.
And then they subsequently put me on additional HIV drugs, Crixivan and a slew of other medicines, on top of the AZT, the Epivir, and the Bactrim.
Now, were you getting better then?
No, actually I was worse. I was getting bacterial infections, upper respiratory infections. I was constantly in and out of the doctor's office, up at the emergency room. Pneumonias, different bacterial infections, you name it.
This is over the course of how many years?
From 1999 up until 2003, when I found out Labor Day weekend that I did not have it.
Okay, so in 1999 was the first time that you went to see a doctor, or 2000?
1994.
1994. Okay, and that was when you first started taking medication?
Yes, my doctor put me right on it.
Okay.
Right.
Had you been ill before 1994?
No.
Okay.
Not.
We're going to go take a commercial break, Audrey. I want to pick up where we left off. You're watching In Time TV. This is a special report. I'm Dr. Jonas Moses. This is On the Edge. Please stay with us. Hello and welcome back to On the Edge. I'm Dr. Jonas Moses. This is a special report this hour. We are talking about public health policy and infectious diseases. With me initially is Audrey Serrano. Audrey, just before we took a break, I had just asked you if you had been ill prior to this initial evaluation in 1994. And you started to say no, and I feel compelled to ask a little bit about your background. What was your circumstance in 1994? What were you doing? Were you working at the time?
No, I was going to school. At that point in time, I had just... I believe I had just graduated shortly before that from my diploma in electronics.
Okay.
I had just bought a lot of my own equipment.
Oh, did you have a family?
Yes, I do.
Okay. Did you have children at that time?
Yes.
All right.
When I got diagnosed, yes. At that time, my daughter was only 4.
All right. And how did this, if I may ask, how did this impact your family situation?
Well, at the time when I found out, I totaled my car. I had been sober for...
Because you were upset, or...?
Well, yeah, I was just beside myself, actually. I didn't know what to feel or what to think.
All right.
I had been sober for 3 months, shy of 3 years at that point in time, and I broke sobriety.
Okay.
And I flipped my car on its roof. They had to pry me out with the jaws of life, actually.
All right. And what happened with your family situation at that point?
I ended up pleading out. I ended up going to Framingham, and then from there to Western Mass House of Corrections Treatment Center.
All right.
For 3 months. And then after that, while I was in there, I had my aunt come to my house and watch my daughter for me and stay at my house. And I made sure that everything was equipped and taken care of prior to going to where I had to go. I lost my license for 8 years. When I got out of there, I had to pick my life up again and just begin over. And when I first got out, I broke sobriety one more time. And I found myself sitting in a puddle of water. It was outside, you know, on the ground, in the pouring rain, and full of mud, crying and wondering, you know, is this what I want? You know, what am I going to do? Am I going to die or am I going to live? And I decided that I wanted to live. I wasn't ready to die, and my family needed me as well. So that's where I think the turnaround began.
All right.
And I started picking my life up, and I just got sober this time on my own, without going anywhere. And
when you began taking the medication for this HIV positive diagnosis, were you drinking at that point, or taking any other illicit drugs, or anything else?
Just alcohol.
Okay.
I took my AZT and Apivir and all that kind of stuff from the time that my doctor diagnosed it.
Right.
When I first found out, I wasn't on anything.
I see.
But before I went to Framingham, I was on the cocktail already by that time, because I had already brought my doctor the paper.
Because they had insisted on it.
Yes, well, they told me that I had it. They gave me the paper over at the family practice clinic over on Ashby State Road.
Okay. Let me ask you, just so that I'm clear on this, did anyone ever draw blood, take the blood to a lab, as far as you know, and isolate a virus?
The only thing I know as far as that is the test from family practice.
Do you know what the name of the test was?
At that time, no, I did not.
Do you know what it was?
Now?
Yes.
Yeah, it's the ELISA.
Okay. That's all I needed to know. So we fast forward. In 2003, we spoke, and at that time you had already decided that you might have had a misdiagnosis, and you were trying to make sense of things. I put you in touch with a physician, with a colleague of mine, a PhD who's a PhD in neuroscience and also a cancer biologist and cell biologist, Dr. Maniotis. I'd like to introduce you to the program as well now.
Hey, Jonas.
Welcome. Thank you very much for joining us. And Dr. Maniotis picked up the conversation with you, and subsequently, over the next almost 5 years, you worked together in sorting through this disease process. And recently, what happened? You went to court.
Yes.
And what happened in court?
Well, recently, we had the case had been pending for like 5 years, and then I had a really, really tremendous attorney, David Anguera from Swartz and Swartz,
All right.
who has been a godsend to me. He's been
And what was the nature
so
of the case?
supportive. The case was against my doctors for misdiagnosing and for not treating,
All right.
as well as not well, according to the documents and the records and biology and that sort of thing, they should have ran the Western blot after they had diagnosed me with the ELISA, which they never had.
All right.
And there
It was just against the doctor?
Yes, and well, initially it was against a bunch of doctors as well as hospitals.
All right.
It ended up...
We're going to go to a commercial break right here, and when we come back, we're going to pick up this conversation. Welcome back to On the Edge. I'm Dr. Jonas Moses. This hour we are talking about, this is a special report, and we are talking about public health policy and infectious diseases. We've been speaking in the last two segments with Audrey Serrano, who had a rather serious medical misadventure. Her disease was misdiagnosed, and she was treated on the basis of a misdiagnosis, and it made her quite ill. I want to introduce into the conversation Dr. Andy Maniotis. At the beginning of the end of the last segment, that briefly mentioned you. Dr. Maniotis, Andy, you are the director of the Laboratory for Cell and Developmental Biology at the University of Illinois in Chicago. You are also a special correspondent to On the Edge. As well with me is Dr. Rodney Richards. Thank you very much for joining us, Rodney. I sure appreciate it. And I did want to just give a little bit of background on you. The audience is pretty well known to our audience, Andy. But just to give a little bit of background, Rodney received your your MS in organic chemistry from the University of Denver, and you completed your PhD in bioorganic chemistry at the University of Colorado. After you graduated, you worked for a small medical startup biotechnology company, which ultimately became known as Amgen. And I think most of our audience will know Amgen. And during your stay at Amgen in Boulder, Colorado, you pioneered the development of the chemistry and molecular biology that now forms the basis for routine DNA and gene synthesis. Using this technology, you designed and synthesized a novel interferon molecule that was approved by the FDA in 1997 for use as an antiviral drug in the treatment of hepatitis C. You also have numerous other patents issued and regarding diagnostic technologies that you developed while at Amgen, including HIV tests. And I want to stop there for just a second, go a little bit more into your more recent background, to ask you about the kind of test kits that you were working on at Amgen and apparently which are still in use today. Can you talk a little bit about the science?
Yeah, of course. Actually, I started working in the field of diagnostics in 1984 when I was employed with Amgen Incorporated as a collaborative effort with Abbott Laboratories right here in North Chicago.
Okay.
Abbott had perfected the pipeline of taking technology, if you will, and pumping out products. This collaboration had the intent of utilizing Amgen's high-tech, biotech, and fusing that with Abbott's ability to pump these technologies into products. So very early on, I was working in a field called DNA diagnostics, or DNA probes at that time. This was an extension of our ability to create genes from scratch or genetic material from scratch. And these new high-tech probes held the potential to increase dramatically the sensitivity of diagnostic tests. By sensitivity here, I mean detecting smaller and smaller amounts of germs.
Okay.
So that was the brilliance of the technology.
And when you say germ, it's kind of a generic for any infectious agent.
Yeah, that's the nice thing about high tech, is that once you do it for one germ, you can fairly well apply it to all other germs.
Okay. But is that was that the case in molecular testing? Or I referred to a conversation we had previously, and I asked you about this, and you mentioned that perhaps when we were looking at the molecular level, we've put our eyes too close to the process, and we're no longer looking at the whole.
Yeah, that's correct.
Disease.
And I think high tech has its advantages. As I mentioned, higher throughput, lower cost, more sensitive diagnostic tests, but it also has its downsides. And I think it takes us further away from the patient. And I'd like to refer to a quote from a Chinese Buddhist scholar in the year about 600 AD who said the superior physician listens to the voice, the ordinary physician looks at the color, and the inferior physician feels the pulse. So I wondered what he would say about those that look at the molecules of the body. And it's not that you shouldn't look at molecules, it's not that you shouldn't measure the pulse, and it's not that you should not look at the color. But with these high-tech tests, I think they have now formed the foundation of a lot of healthcare providers' treatment strategies, and forgetting that there's the patient out here too. And they need to use their clinical practice to inform their treatment decisions. Many of the tests that we use routinely, such as the antibody tests that were used in your case, are they're clearly overused. These tests, in and of themselves, were not intended to form the basis of a diagnosis of infection with HIV, at least according to the Food and Drug Administration and the manufacturers that use them.
In fact, I wonder if I could, can we have the first slide? I just wanted to kind of emphasize this. This is an insert in the test kit, and I wonder if you could read that. Are you able to read that, Rodney?
Yeah, I can. It says, at present there is no recognized standard for establishing the presence or absence of antibodies to HIV-1 and HIV-2 in human blood.
And this is a current insert, and I might note that
it's like 33 other test kit inserts as well.
There are similar conditions on all of the test kits for this particular infectious disease. My question is, if the manufacturers of these test kits have an issue, in other words, feel compelled to put this kind of caveat on their packaging, why are these kinds of test kits used as the sole determinants for infectious agents?
Well, they should not. Again, the FDA, when they approved the so-called Western blot, which is the confirmatory test for the antibodies that are detected by the screening test, clearly stated that these tests should not be used in asymptomatic populations. In other words, in the absence of symptoms, to inform a clinician's decision of infection, the significance is unknown, as the FDA says. So they should not be used in that manner. However, the various government bodies that we have different functions. For example, the Department of Public Health, the Department of Health and Human Services, the Centers for Disease Control have the mission of public health. Okay, whereas the FDA has the mission of individual health.
I want you to hold that thought. We are going to take a commercial break. When we come back, we'll be talking to Audrey Serrano, Rodney Richards, and Andrew Maniotis. I'm Dr. Jonas Moses. You're watching On the Edge. Welcome back to On the Edge. I'm Dr. Jonas Moses. This hour, a special report. We are talking about public health policy and infectious diseases. With me, Dr. Andrew Maniotis, Dr. Rodney Richards, and Audrey Serrano. Dr. Richards, Rodney, you were just talking about you were differentiating between the various organizations. You were just making a point about the FDA.
Right. As I was saying, that the FDA has the mission to protect individual health. I think many of us have forgotten this, that the mission of the FDA is consumer protection. That was why it was born. And for that reason, they require something called scientific proof before they can recommend that a product be marketed for treating illness. On the other hand, these other departments of our government can make recommendations with the interest of public health. They're sincere, okay, but they're conflicting with the individual health paradigm. Because in a case, ignoring HIV, any infectious disease, the CDC will encourage mass testing in order to prevent the spread. Even if the test is 50% false positives, from a public health point of view, it doesn't matter, okay? But people today are not being informed as to what the package inserts on these tests that are being used at the individual level. And
we call this informed consent.
Exactly, and I think we're living in a culture where not only is informed consent being thrown out the window, but merely questioning today the validity of a test or informing somebody is considered to be heretical. It's like I'm accused of sowing confusion, if you will, for telling somebody that this particular test, it could be West Nile, HCV, HIV, none of SARS, right, none of these are approved for diagnosing infection, and physicians don't know this either. I think that they have become detached by the consolidation of diagnostic testing at central locations, the physician doesn't really know what the limitations of these tests are.
The reason for that is because we're not allowed to teach that in medical school, and when we do, we are the targets of massive letter-writing campaigns by Robert Gallo and John Moore and Mark Wainberg and other people who are trying to take our jobs away for questioning the science of these things. And what you said before about testing everybody and mandatory testing of populations is going to be the greatest crime against the American public and every other civilization on the planet, because, as you said, when you test a low-risk population, you're going to get an incredible number of false positives. As a matter of fact, everybody who tests positive is a false positive in a low-risk population, so it becomes a matter of, like a recent commercial that's been funded by people, you can actually tell what somebody looks like when they're HIV infected. They're black, they're prostitutes, they're gay, etc. You see, and that's where the test kit leaves off from the diagnosis in the doctor's office, because we can't train the physicians. They can't even get into medical school without an HIV test, which is, in some ways, a real tragedy.
Well, but and I want to pull the conversation back here, because I think it's incredibly important to appreciate, and certainly for the viewers to appreciate, that this is much larger than any one disease process, Andy.
Of course.
That the issue here is that we have gone down a road, and I'm trying to grasp, the reason you're here today and we're having the conversation, I'm trying to help my viewers grasp how we got down this road, how we can come back from this road. I don't think it's useful to engage in a conversation where we talk about any one individual or group. I think what's more important is to talk about what we can do right.
Well, I think it's simple. I think it's really simple, and that is that you don't presume people are sick based on any one criteria, as is done today. You cannot take a patient and in a population and say that this constellation of characteristics means this. You have to do what Dr. Richards said and listen to the voice, take the molecular test, do all these things, present it to the patient, and not let the government get between the doctor and the patient, as is what's happening today with violations of the Nuremberg Code. Physicians cannot treat their patients. They have to follow a protocol. If they don't, they get sued.
Go ahead, Audrey.
I'd like to bring something up that I think is really important.
Yes.
I think that it's really important that if a patient goes, let's say a new patient goes to see a doctor, they come in with a diagnosis of whatever that diagnosis is. It doesn't matter what it is. And they're going in for treatment for that thing, like let's say even cancer, HIV, what is that, hepatitis B or C or whatever. It doesn't matter. If they go into a doctor and they say, okay, I've been diagnosed with this, I think it should be made mandatory that they do a confirmatory test just to make sure that that person has what they say they're having, even if they come from another doctor or whatever, cancer or anything else. I think that it should be confirmed and definitely shown that they have it.
Okay. Dr. Richards, Dr. Maniotis, what can we do that's not already being done to develop tests that are more accurate, and what should we be looking at? Plainly, molecular markers are not enough. What else do we need in the mix to accurately diagnose infectious disease?
You want to speak to that first? Or?
Yeah, I would like to share just a short experience that I had when I first went to work at Abbott Laboratories in collaboration as a scientist at Amgen.
Please.
I had met a microbiologist. Okay, microbiologists are the people that actually grow germs. They look at the germs, they characterize the germs. They can't necessarily say that this constitutes a causal relationship to a disease, but they can actually identify the germ. You were saying you would like to have doctors confirm the disease. Okay, in the old days, this is how it was done with microbiology. They actually grew your germ, and they could look at it and characterize it. Okay, and now we've drifted from that. And I was talking to this...
When we've drifted from that, is that a good thing or a bad thing?
Well, it could have been a good thing, and it still can be a good thing. I talked to this person, and she looked at me and she said, "You better be careful because you're going to start to see things that don't exist."
Okay. Like?
I said, well,
diseases that don't exist?
Yeah, because we're looking at molecules. It's kind of like finding a nail and concluding that a house is somewhere in the room. And so you can find molecular fragments very easily. And I said, well, that's where you come in to make sure I'm not making a mistake, right? And she said, they just got rid of me to make room for you.
So they got rid of the
microbiologist
to make room for the molecular biologist.
Right. So that it was partly a financing problem. They had to start cutting. It's a very expensive practice. But we need those microbiologists back so that when we do have a diagnostic test for HIV, HCV, West Nile, or whatever else, that we can actually confirm it.
And today,
if we can't, just one other thing, if we cannot confirm it, we should tell the patient that. Say, I'm sorry, you know, I can't tell you with certainty. However, I can tell you that based on my 10 years of experience, that it's very likely if that's the case. Go ahead.
Well, you're absolutely right, because nobody has seen HIV to date as long as it goes back to 1984. And why should you have to do PCR and amplify something if it's in such high viral load? I mean, they were giving Audrey viral load tests over and over again with a high T-cell count and wondering and scratching
What
their
is the
heads.
significance of a high T-cell count?
Well, it means that she's not experiencing the so-called decline of the immune system that is
associated with this disease.
Characteristic of HIV/AIDS.
Okay.
Although Gallo in the beginning said you have Kaposi's patients with no T-cell defect that they could detect.
All right.
To date, nobody has seen the virus. You know, show me the virus, as what you're saying is absolutely correct. And if you
Or the
need
infectious
PCR
agent.
to amplify it,
Sure.
why
Hold on one,
then
folks.
it's not at
We're
high
going to go
count?
take a commercial break. Please hold that thought. Stay with us. You're watching On the Edge, and this is a special report. I'm Dr. Jonas Moses. With me, Rodney Richards, Audrey Serrano, and Andrew Maniotis. We'll be right back. Welcome back to On the Edge. I'm Dr. Jonas Moses. This hour, a special report on public health policy and infectious diseases. During the commercial break, I asked my guests a question on that issue of the larger population. As patients, at one time or another, all of us might go into a clinic or see one healthcare professional or another, and in the absence of any real direct isolation of a disease, of an infectious disease process, we begin treatment. As I said, in the United States, in the Western world, we have some checks and balances, someone in our lives who's saying, wait a second, you should get a second opinion, or wait a second, see another doctor, or wait, here's a specialist who can really help. But in most countries in the world, outside the first world countries, which represent the lion's share of the 7 billion people in the world, there is no advocate for the patient. So, Audrey, you wanted to pick up on this.
Yes, there's something really important to do with the medication and in relations to the diagnoses and so forth. Even if someone's been diagnosed with HIV and they're being treated in a clinic for it, according to what I learned during my nightmare with it, after finding out that I was negative in false diagnoses and that sort of thing, I learned that a person should not even be on the cocktail or the drugs or AIDS drugs or of any kind unless they go below 200. In my case, I never reached below 200 according to my records, yet when I first found out, they had me on the drugs, which was killing me. Ultimately, it was the drugs that were killing me, as we obviously know, and proof positive.
Okay, I want to pick up on that really quickly. We have a limited amount of time, but I do want to point out, because I wanted to do my homework here, and I knew that you had been treated with AZT, and I just want to read what I learned. AZT is a highly toxic chemical compound originally created for use as cancer treatment. It's a no-nucleoside analog drug or a DNA chain terminator, meaning that it stops DNA from replicating. Ultimately, it therefore destroys all growing cells in the body, and that it includes new cells produced in bone marrow where the immune system is generated. In 1964, experiments with AZT on mice with cancer showed that it was so effective in destroying healthy growing cells that the mice died of extreme toxicity. As a result, the drug was shelved and no patent ever filed. And yet 20 years later, this same drug was resurrected and remarketed as an anti-HIV drug. So my question is, one, how does something, Rodney, how does something like this happen, that a drug that's...
Broder did it in his deliberations, and when Harvey Bialy was sitting next to him...
Who was Harvey Bialy?
He was the former editor of Nature Biotechnology. He started the journal.
Okay.
He thought he was sitting next to Goebbels because he knew the toxicity profiles of AZT. And when he showed them, he was ignored, and they used it anyway, and they passed it in a record 4 months.
And this was in 1984, 85?
1987 official
87?
trial when
All
they
right.
showed that all the patients were dead after 3 years that were on it. Great drug, I say. I mean, but nevertheless, it became the mainstay for treatment, and it corresponds to the overwhelming death rate of the gay population. Essentially, it was a systematic genocide against gay men of that period.
Okay.
You're not sugarcoating it, are you?
Yeah.
I'm not
Okay.
sugarcoating.
No, I don't
All
want
right,
to. I don't want to
yeah,
pull any. What I don't want to do is assassinate any one drug group or anything like that. What I want to do is I understand that, but what I want to do is point up. The conversation I want to have for the rest of the program here is about what we can do differently now. Plainly, some of these efforts were well-meaning. People were trying to help patients. They're trying. All of these organizations, I have to believe, in their heart of hearts, the physicians, the research scientists, the drug companies, all want to help folks.
Well, I'll tell you, to answer your question about how did that happen in the first place, it happened because of something we call tissue culture data. In other words, we were seeing, again, molecular phenomena at the molecular level in tissue cultures. And that's where it appeared that there could be a positive effect to this molecule, regardless of how toxic it was. That is what justified the trial itself.
Okay.
Perhaps we need to have a little more stringent animal testing, for example.
Right.
But we already knew in this case that this molecule was toxic, and it wasn't that important. So that's one problem, is that we are eager to jump into these clinical trials, and then we're also eager to halt them early on the basis of what we perceive to be beneficial effects.
Okay. So studies should be going longer than they are.
Of course, they should enroll more people. They should go longer, and there should be, as you mentioned, your T cells never went below 200. Okay, that's what this drug was approved for.
And that's why.
Yeah, and the Department of Health and Human Services, at the same time that you were being treated, had recommended 1,000 or even more than 1,000. It was an aggressive campaign that became known as Hit Early, Hit Hard. That's what was really harming people.
David Ho was the name.
Okay,
that
but
came up with that.
that's where the damage was coming from.
Right.
Is off-use, off-label use.
Yeah, well, that's why I wanted to bring up that, because I think it's so important for other people out there who don't know this information. You know, if their counts are not below 200, then they should not be on the cocktail, according to the CDC.
All right.
Okay,
and this one particular disease we're talking about.
Yes, in HIV/AIDS diagnoses.
Okay.
If their count is not below 200, according to the CDC and all the research that I've done myself, they should not be on the cocktail.
Well, good point. And everybody is back.
You know, a lot of people don't know that, and then they get sick. If they're not already sick, then they get sicker from the drugs, and it's not actually from the illness, it's from the drugs.
Okay, so constructively, again, I want to come back to this. Constructively, what can we do now?
Well, the first thing to do is reappraise these diseases and their so-called causes.
Okay.
That's the first thing that should be done.
So we need a
wide
continued
scale.
dialogue here.
On World AIDS Day, we came up with World Reappraising AIDS Day. Okay. And it got wide press because we want to review the data that led to these public mandates, public health mandates, and we want to do it perhaps in Greece in November in a large debate between the two sides, as we did in Durban in Africa. That's the first thing that needs to
go there. We're going to take a commercial break. You're watching On the Edge. I'm Dr. Jonas Moses. With me this hour, Dr. Rodney Richards, Audrey Serrano, and Dr. Andrew Maniotis. Stay with us. Thank you for staying with us this hour. You are watching On the Edge. I'm Dr. Jonas Moses. This is a special report. We are talking about public health policy and infectious diseases. With me to discuss that, Dr. Rodney Richards, Dr. Andrew Maniotis, and Audrey Serrano. And right before the commercial break, you started talking about, I had asked the question of the panel, what can we do right from here on out? What are some progressive things we can do?
Well, right away we can have a dialogue to reappraise the fact that nobody's ever seen or isolated HIV
or other diseases,
especially the ones that have had an association with cancer, which is my interest. Hepatitis B was supposed to be the cancer-causing virus.
All right.
They came up with the hepatitis B vaccine for that reason. Now HPV is supposed to be the other first cancer vaccine. The same company forgot that it made the claim originally that Hep B was the first anti-cancer vaccine, and now they're saying HPV.
So what can we do differently?
Well, what we can do is, instead of attacking these things with such fear, We should look at the history of disease a little bit more carefully.
Okay.
We should begin teaching medical students. I work in a pathology department, and I'm not allowed to raise concerns about the test kits that we give patients. All right? Recently, a mother was thrown in solitary confinement because she wanted a second opinion on a melanoma. I testified, and the judge threw it out. I mean, that should not be happening in this country. The reason it's happening is because there is this disconnect, as Dr. Richards was saying, and as Audrey has said, between the classic doctor-patient relationship. We need to appeal to doctors. They're our last hope. They're the last great hope, because the corporations aren't going to do it. The U.S. government's not going to do it. It has to happen in the doctor's office. They have to say there's a sacred relationship between the doctor and the patient that the government should not be interfering with.
Okay.
That's a violation of so many laws, international laws, etc.
Dr. Richards, Rodney, you did some research, rather extensive research in sub-Saharan Africa and Africa. Dr. Maniotis is talking about the West, the United States in particular. What about other countries? What about third world countries? What can we do there that we're doing different than we're doing now?
Well, we're basically colonizing these developed countries with Western notions and Western medicines. There are education campaigns that I think can be effective if they target the right populations. But it's interesting that it seems to me that the patients themselves in sub-Saharan Africa are the ones that are their own advocates. If they don't like the drugs, they quit.
Okay.
They don't.
So they take themselves off.
Right, and this is something I said, that patients also have a responsibility. Look, here's a woman who took responsibility for her health, and look what happened. She went from having a death sentence to now closing on her home. Okay, and a very bright future.
Not before they took a daughter away from her and treated her like she was some sort of criminal for 13 years.
And I want to point that up, and because we have very little time.
Right. So patients have to become involved, and as I said, we've handed over our health care to doctors like they're gods in this country. In general, I'm speaking in very general terms.
And even doctors will be patients
right.
at some time.
Africans don't have those gods.
All
okay,
right.
so what do? They listen to their own heads,
All
and
right.
this is why 40–50% of the population that goes on to these medications for AIDS in Africa quit after 2 or 3 years, and I think they're really not. They're not caught by this paradigm that we have to have the doctor tell us what to do. So I think that is the little bit of good news that there might be.
It's also the constant Gardner syndrome with the sperm
reference to a movie.
the microbicide campaigns of John Moore, where they double the rate of HIV infection, or the breastfeeding dissuasion campaigns where there's 20 times the infant mortality in the women who have been told they'll give HIV to their children, or the Nevirapine campaigns by Tremont, the head of the AIDS program, who says that I can give Nevirapine to 875,000 African, because they have to be black or from a country where the people really don't matter, the constant Gardner syndrome. I can give this drug that's so toxic that it was withdrawn from the U.S. because we don't want to waste money on it. Let's dump it on them, and then increase the so-called resistance rate of HIV to 41.7%.
Okay,
we have
just a brief moment left. I want to thank all three of you for joining me. This is obviously an incredibly important conversation, and plainly there's an awful lot more to cover here. I hope that I'm able to engage the three of you and others in a panel discussion in the near future. Thank you so very much for joining us, Dr. Richards. Audrey, thank you for joining us, and I look forward to continued improvement and success. I know that your condition has been substantially damaged by the drugs that you were using.
Before we close, can I give credit to a couple of people?
Yes, of course.
I'd like to give credit first and foremost to my mother, Shirley Pascal,
Okay.
and my family, to Andrew Maniotis, to yourself,
Thank you.
to my attorney David Anguera and his firm, Swartz & Swartz, Attorneys at Law in Boston, Mass.
Okay. Well, thank you
for
very much.
all of your support, because I didn't do this all by myself. I'm here and you guys are looking at me like I did all this, and I just want you to know that I didn't do it by myself.
They couldn't have done it without you.
Right. Dr. Andrew Maniotis, as always, a pleasure. This is obviously an incredibly challenging and controversial conversation. I cannot encourage you enough to consider the following, that we don't have all of the answers. We have very few answers here among us. No one person or group has all of the answers. Plainly, this is a question of us all taking a good, hard look at these paradigms, taking a good, hard look at the conventional wisdom around infectious diseases, and to recognize that we all, at some time or another, are going to be patients. The net is, we all want what's best for the end user, the patient. To that end, I hope that you take the time, do your homework, investigate what's out there, ask and reevaluate and reassess over and over again, and don't accept any paradigm as the ultimate fact. If we stop questioning these paradigms, we stop engaging in the scientific process, and that's where science and medicine ends and religion begins. You've been watching this hour on the Edge. This has been a special report talking this hour about infectious disease and public health policy. I've had the good fortune of having joined me Dr. Rodney Richards, Audrey Serrano, Dr. Andrew Maniotis. Again, anytime you wish. I also have a blog site, that's jonasmoses.blogspot.com. I have been posting to YouTube, that's a website on the internet, youtube.com, past shows that I've done. So these are shows that are archived. Please visit those. Please visit my blog spot. I'm Dr. Jonas Moses, on the Edge.